My name is Terry King. I'm the Chief of the Division of Breast Surgery at Dana-Farber Brigham and Women's Cancer Center and the Associate Chair for Multidisciplinary Oncology in the Department of Surgery at Brigham and Women's Hospital. When breast-conserving surgery, or otherwise called lumpectomy, is performed, it is very important that we are confident that we've removed all the disease. And the way that we determine that is by an assessment of the margins from the lumpectomy specimen. So when there is an abnormality within the breast that we decide that we're going to perform a lumpectomy, we remove the abnormal area either by palpation, or if it's not palpable, our breast imagers help us with the localizing technique, but we remove the abnormality with a rim of normal tissue around the edge. And that rim of normal tissue is our margin. Now, in the operating room, we are not able to accurately determine whether we have achieved a clear margin. And so we really rely on our pathologists who examine that tissue post-operatively to look at that edge or to evaluate the margins. Now, there are different techniques by which surgeons and pathologists can work together to evaluate the margins. The important thing is that when the surgeon removes the tissue, it needs to be oriented for the pathologist, so the pathologist knows, for example, what side is top or bottom or right or left on that piece of tissue, so that if he does identify cancer cells approaching the margin or at the margin, he's able to then relay back to the surgeon which margin in fact is problematic or which margin has cancer in it. So the pathologist evaluates the margins under the microscope, looking for the tumor cells coming up to the edge of the piece of tissue that the surgeon has removed. Now, as I mentioned, there are different techniques that surgeons and pathologists can work together in order to optimize the evaluation of the margins. One of the techniques that we use is called cavity-shaved margins. That means that when I perform the lumpectomy, my pathologist knows that that primary lumpectomy specimen is not the final margin evaluation. I then remove additional tissue from inside the cavity, inside the lumpectomy bed, from each wall individually. And so I send my pathologist individual specimens labeled superior margin, inferior margin, medial, lateral, etc. And they know that those pieces of tissue are the ones that they need to evaluate for the presence of cancer cells coming up to the edge of the tissue. This technique has been demonstrated to reduce the need for re-excision or reduce positive margins. But of course, again, there are many ways that surgeons and pathologists can work together. And the important thing is that they have a system and that your surgeon is able to tell you that you have achieved a clear margin in the setting of breast conserving surgery.